Chronic adrenal insufficiency, hypocorticism. The topic about adrenal diseases includes this very serious disease. Chronic adrenal insufficiency is accompanied by a deficiency in the hormones of adrenal cortex, glucocorticoids, mineralocorticoids, and adrenal sex hormones. Hypocorticism is a syndrome that includes all diseases accompanied by a deficiency of adrenal hormones. Classification of hypocorticism includes primary hypocorticism and secondary or central hypocorticism. Both of these type of hypocorticism shared to congenital and acquired. Characteristic of primary hypocorticism. Primary hypocorticism is caused by damage of adrenal cortex and decreasing of hormones production due to various etiological factors that cause pathogenetical changes in adrenal glands. Congenital hypocorticism may be due to a deficiency of enzymes involved in the synthesis of glucocorticoids and mineralocorticoids, congenital adrenal dysfunction, or hypoplasia or aplasia of adrenal glands or one of adrenal gland. Acquired hypocorticism most often developed as a result of autoimmune lesion. Adrenalitis, autoimmune adrenalitis, tuberculosis, adrenoleukodystrophy, or after adrenal ectomy. Some drugs, antifungal antibiotics, block steroidogenesis and can cause to iatrogenic hypocorticism. Characteristic of central hypocorticism. Secondary central hypocorticism is a condition caused by damage of the pituitary or hypothalamic, decreasing of adrenocorticotropic hormone and adrenal cortisol due to various factors. Congenital central hypocorticism observed due to hypoplasia of pituitary gland or isolated ACTH deficiency, but is more often diagnosed as a part of hypopituitarism. Acquired central hypocorticism developed after radiation or surgical treatment of pituitary adenomas due to traumatic brain injuries and hemorrhages, tumor, or pituitary cysts. Drugs, dopamine agonists, glucocorticoids inhibit the production of ACTH. Clinical manifestation of hypocorticism. The leading clinical symptom is arterial hypertension. It should be clarified whether there have been changes in the blood pressure profile and that medications the patient received. First of all, the rest of the subjective and objective clinical signs are not specific, and therefore hypocorticism is difficult to diagnose through the world. Most cases of primary adrenal insufficiency are diagnosed with the adrenal crisis or Addisonian crisis, accompanied by critically low blood pressure or hyponatremia. Clinical manifestation of hypocorticism includes the complaints about weakness, poor appetite, rapid heartbeat, dry skin, dyspepsia, vomiting or diarrhea, back pain due to osteoporosis. Attractive symptoms, very important to suspect hypocorticism. The presence of hyperpigmentation, elbows, knees, places of friction of the skin with the clothing, active interrogation about weight loss and appetite, craving for salty meals, allergic reaction in anamnesis. Psychological portrait of patient. Depressive mood, moody. The sun does not shine, so the grass is not so green. It's true. Justice of the peace. My opinion is the most correct. The last word is mine. Heightened sense of justice. Characteristic of laboratory test. Very important laboratory test with attractive changing in the general blood test like lymphocytosis and eosinophilia. Increasing of creatinine and urea concentration levels in biochemical blood test. Hyponatremia and hyperkalemia like scissors in the ionogram. Hypercalcemia is important too. Hypoglycemia doesn't often reveal because patients do not tolerate hunger. They eat often but are quickly satiated. Autoimmune primary adrenal insufficiency. It can be seen as isolated disease or as a part of autoimmune polyendocrine syndrome, often in combination with autoimmune hypoparathyroidism, autoimmune thyroiditis, or diffuse toxical goiter. In combination with autoimmune non-endocrine diseases like vitiligo, autoimmune alopecia, autoimmune hepatitis, etc. Diagnostic of hypocorticism. Verification of hypocorticism is based on determining the level of cortisol in a blood serum, determining the concentration of cortisol in daily urine, determining the level of ACTH, which allows to differentiate between primary and central hypocorticism. But recently, it has been recommended to determine beta lipotropin in daily urine. Next test, the stimulation with synthetic ACTH and insulin. It can stimulate ACT production and diagnose the central hypocorticism in majority of cases with this test. Test of titer of 21 hydroxylase antibody to confirm autoimmune injury. Very important test because the majority of cases of primary hypocorticism due to autoimmune lesion. Computer tomography of the adrenal glands and MRI of the hypothalamic pituitary zone. The principles of treatment of hypocorticism. Both primary and central hypocorticism are cured by glucocorticoids and mineralocorticoids replacement therapy. Glucocorticoid drugs with the optimal substitution activity, cortisone acetate and hydrocortisone, prednisolone can be used too, but we can control with laboratory test of cortisol level the replacement therapy with cortisone acetate and hydrocortisone. Mineralocorticoid drugs, fludrocortisone or cortinef. Monitoring of compensation and adequacy of replacement therapy provided with serum cortisol and potassium level test. We try to make correct treatment with a normal kalemia level. Thank you for your attention.